Time interval before pregnancy. Advice on postponement of pregnancy should be individualized and based on treatment needs and prognosis over time. Most women should wait at least 2 years after treatment, which is when the risk of cancer recurrence is highest. Women are generally advised to wait for at least 2 years after treatment for breast cancer before conception because of the risk of early relapse. The rate of disease recurrence is highest in the first 3 years after diagnosis and then declines, although late relapses do occur up to 10 years and more from diagnosis. Women with estrogen receptor positive disease should be advised that the recommended duration of tamoxifen treatment is 5 years. It has been suggested that women with good prognosis need not wait 2 years to become pregnant. An understanding of the prognostic factors affecting the individual woman tumor size, grade and nodal status, estrogen and progesterone receptor, and human epidermal growth factor receptor 2 status should enable the oncologist to give appropriate advice. This is of great importance to the woman desiring pregnancy who may need to weigh up the benefit of postponing conception, for example, to complete prolonged adjuvant therapy with tamoxifen against the risk of infertility as a result of delay. Outcome of pregnancy. The majority of pregnancies after breast cancer proceed to live birth. Women are more likely to terminate a pregnancy when it occurs soon after treatment or during adjuvant therapy. Women can be reassured concerning the risk of malformation in children conceived after treatment for breast cancer. Most of the available data do not show any increase in congenital malformations or stillbirth among the offspring of women who have completed treatment for breast cancer. The heritability of breast cancer is a source of anxiety but does not affect childhood health. Women who are known to be breast cancer gene carriers may wish to consider pre-implantation genetic diagnosis. What is the optimal management of pregnancy following treatment for breast cancer? Pregnancy following breast cancer should be jointly supervised by the obstetrician, oncologist, and breast surgeon. Echocardiography should be performed during pregnancy in women at risk to detect cardiomyopathy through resting left ventricular ejection fraction or echocardiographic fractional shortening. During pregnancy, a breast treated by surgery or radiotherapy may not undergo hormonal change, and the woman may require a temporary prosthesis. If breast imaging is needed, ultrasound, performed through the breast multidisciplinary team, is preferred. Metastatic relapse may be harder to detect, and common complaints in pregnancy, such as backache, can be difficult to assess. These women may have received adjuvant chemotherapy with anthracyclines such as doxorubicin and epirubicin, which can cause cumulative dose-dependent left ventricular dysfunction and rarely cardiomyopathy. A slightly increased risk of delivery complications and cesarean section has been reported in breast cancer survivors. The supervision of pregnancy after breast cancer should be consultant-led, but midwifery involvement will help to normalize care. What advice should be given to women wishing to breastfeed following treatment for breast cancer? Women can be reassured that they can breastfeed from the unaffected breast. There is no evidence that breastfeeding increases the risk of recurrence in women who have completed treatment for breast cancer. Breast-conserving surgery may not inhibit lactation in the affected breast, but radiotherapy causes fibrosis, making lactation unlikely. There is no evidence that previous chemotherapy affects the safety of breastfeeding. In view of the well-recognized benefits of breastfeeding to the baby, women who wish to breastfeed should be encouraged to do so. Midwifery supports helps to establish successful lactation. What is the effect of breast cancer treatment on the woman's fertility? The effect of treatment on fertility should be discussed with all women of reproductive age diagnosed with breast cancer, and written information should be provided. Referral to a fertility specialist should be available. Specialist counseling should be available. Infertility after treatment is a major concern for young women with breast cancer. Women's preferred source of information on fertility is consultation with a fertility specialist, backed up by an information booklet. A recent joint working party of the Royal Colleges of Physicians, Radiologists and Obstetricians, and Gynecologists in the UK recommended that people with cancer should be fully informed of potential gonadotoxicity before treatment, and that specialist psychological support and counseling should be available. What is the effect of adjuvant chemotherapy on fertility? Chemotherapy-induced gonadotoxicity may cause permanent amenorrhea with complete loss of germ cells, transient amenorrhea, menstrual irregularity, and subfertility. The degree of gonadotoxicity is dependent on the specific agents used, the cumulative dose administered, and the woman's age. Amenorrhea is reported in 20 to 70% of premenopausal women with breast cancer, but the rate ranges from less than 5% in women under 30 years of age to 50% in women aged 36 to 40 years. Alkylating agents such as cyclophosphamide have well-recognized gonadotoxicity, and the classic CMF regimen or the cyclophosphamide methotrexate 5-fluorouracil causes a higher incidence of amenorrhea than anthracycline-based regimens such as FEC or the 5-fluorouracil, epirubicin, and cyclophosphamide. The newer taxanes appear to be less gonadotoxic. What is the effect of adjuvant hormonal therapy on fertility? The agents used for adjuvant hormonal therapy do not in themselves cause long-term effects on fertility. Tamoxifen, a selective estrogen receptor modulator, often causes menstrual irregularity, and there is an increased risk of endometrial pathology. Conception during tamoxifen therapy should be avoided because of potential teratogenicity, and a washout period of 2 to 3 months is advised. Gonadotropin-releasing hormone analogs cause amenorrhea and profound estrogen deficiency. Women may find the menopausal symptoms worrying, but the effect is entirely reversible. Trastuzumab is a monoclonal antibody that binds selectively to the human epidermal growth factor receptor 2 protein expressed by some breast cancers. There is no evidence that it impairs fertility, but pregnancy is not advised during treatment. What advice should be given to the women about postponement of pregnancy before embarking on further pregnancy? Women are generally advised to postpone pregnancy for at least 2 years after treatment and may be advised to continue tamoxifen for 5 years. However, age is a major determinant of fertility, and delay with already poor ovarian function owing to chemotherapy is likely to lead to infertility. Women in their 30s desiring pregnancy may wish to discuss the value of prolonged treatment with tamoxifen and consider discontinuation after 2 to 3 years. Can fertility be preserved before treatment? At present, only a minority of women of reproductive age undertake fertility preservation procedures, and there are scarcely any data on long-term outcome. Gonadotropin-releasing hormone analogs. There are insufficient level 1 data to support the routine use of gonadotropin-releasing hormone analogs for ovarian protection in estrogen receptor positive breast cancer. Gonadotropin-releasing hormone analogs have therapeutic use in hormone-sensitive breast cancer as they induce profound ovarian suppression and create a low estrogen state. A recently reported randomized controlled trial in premenopausal women with breast cancer found that co-treatment with gonadotropin-releasing hormone analogs during chemotherapy lessened the risk of ovarian damage. Cryopreservation. Ovarian stimulation for egg or embryo freezing requires careful discussion in light of a known long-term risk. Modified stimulation regimes should be considered for women with estrogen-sensitive breast cancer. Embryo cryopreservation is a well-established technique with success rates of at least 20% per cycle, although it is possible that success rates may be lower when oocytes are retrieved from women with cancer. The time required for ovarian stimulation and egg harvest may postpone chemotherapy, and there is a small risk of procedural complications such as ovarian hyperstimulation. There is concern that elevated estrogen levels may be deleterious in estrogen receptor positive breast cancer. To minimize this risk, stimulation regimens with tamoxifen or letrozole, usually combined with gonadotropins, are proposed. Oocyte storage may be offered to women without a partner. Freeze-thaw techniques are rapidly improving, but there have been only a few hundred births worldwide after use of this technique, and there are no long-term safety data. There are insufficient data to support ovarian tissue storage for fertility preservation in women with breast cancer. This should be offered only in the context of a research trial. Cryopreservation of ovarian cortex, or the whole ovary, has resulted in a small number of pregnancies after regrafting. This remains an experimental technique, and tissue storage regulations in the UK have restricted its use. The need for surgical procedure is a disadvantage, but this technique does not delay chemotherapy. Every breast oncology service should have a designated pathway for prompt referral to a fertility specialist able to offer assisted conception. Service provision should not be dependent on local in vitro fertilization funding arrangements. The National Institute for Health and Clinical Excellence recommended universal access to sperm, egg, and embryo storage for people undergoing gonadotoxic treatment. Assisted reproduction after treatment for breast cancer. Fertility treatment after chemotherapy is limited by loss of ovarian reserve. The stimulation aspect of in vitro fertilization carries a theoretical risk as it is a hyperestrogenic state, although of shorter duration than pregnancy. Women who have chemotherapy-induced menopause can become pregnant with donated eggs, This requires short-term hormone replacement therapy, which again carries a theoretical risk. Replacement of cryopreserved embryos is also performed in a medicated hormone replacement therapy cycle. Women for whom pregnancy is contraindicated may wish to consider surrogacy.